I'm going to ask a question about your work with myeloma, because that was how we started talking last year about the work that you were doing with myeloma patients. And I'm wondering if you're using the telemedicine for diagnostic, and then you also talked about how patients were being flown to the Arizona Cancer Center for bone marrow transplant. So can you talk about that? Because I'm very interested in that whole issue.
Thanks for bringing that up. That is how we connected. Again, as a clinician, my observation was that it was not infrequent for a patient to come for the follow-up, for whether it's a diagnosis of myeloma or it was a follow-up on their response to therapy, and where, in this case, the intervention, diagnostic intervention that was needed was a bone marrow. And where on several occasions with different folks, they declined the marrow. And generally it was declining it because they really wanted more social support at that time. And so what we had talked about is the importance for education, because it just seemed, a shame for the patient to travel all that way and then to decline the diagnostic intervention that had actually been identified at the referring site. So the patient was coming from Ching-Li, had traveled all that way, and then declined the bone marrow, or from any of similar communities. So certainly something that could be done would be to use the network to explain the procedure to the patient ahead of time in an open format where the patient could ask questions. The patient could be there with family. Family could ask questions. And then perhaps as a family, folks could travel so that the patient would feel that he or she had the necessary support. But I think that developing educational programs that could be delivered through the network would be, if you would agree, I think would be very helpful, and we'd be happy to collaborate with you on that. And it doesn't have to, again, originate from Tucson. It might originate from Flagstaff. One of the things that I think I was really, I really wanted to emphasize as we develop the program is that we really follow normal referral patterns, which is why the hub is not only Tucson. There are multiple hubs, Phoenix, Flagstaff, Yuma. It's really to follow where patients would go. So that if a patient, as we mentioned in the Tuba City example, if the patient is at the chapter house and would normally go to Tuba City, we want to facilitate that connection. If the patient's in Tuba City and would normally go to Flagstaff, we want to facilitate that connection, and so on. So to really, I think of the network as a way to facilitate care. So patient education, online services, we can think creatively. One of the, we're funded actually to develop patient-related outcome tools. And that's something, patients go home after their chemotherapy. Many patients I know receive chemotherapy at Phoenix Indian Medical Center, go home, and then may have symptoms. And there could be a way, again, to use computerized systems where patients can report in their symptoms and get a response more promptly, really, than if they were, certainly than if they're waiting for their next follow-up appointment, and would help their quality of life, would help how they tolerate it.
I find that very exciting because I think in terms of the excellent resources, and you know that we also have for myeloma as a specialty with the Mayo Clinic, with TGen, and that easily with those kinds of facilities, we certainly should be able to connect to you, to patients, wherever they are, to be able to do more of the kind of education that we're quite limited to try to do in one conference a year, and really doing outreach to more rural communities to more cultural communities, so that we could really tailor these programs. So that's very exciting. Certainly we'll be following up with that. Great. Other questions? I know we had a couple people come a little bit late. If they want to ask any questions or comments, you're very welcome to stay with us.
When somebody's newly diagnosed, do they just teleconference like this as well to the patient, or do they send them to an actual provider?
Did you hear that question, Doug?
I didn't hear the whole question.
When somebody is newly diagnosed, do they sit like this in a room and you guys talk to them about it, or do you send them to an actual provider and do a face-to-face consultation with the patient?
So I wish you had the system right there that I could show you. We can do the entire physical exam except palpation. So there are some patients that I follow, cancer patients that I follow through the network. We alternate visits in person and through the network. And the only thing that can't be done is I can't feel an abdomen. I can't feel lymph nodes. But, and again, what I think is so exciting about this is, it's a different kind of translational research, really, because we interact with engineers, and you go to the engineer and you say, this isn't working, and then they come back with a solution, and that's how the whole digitization of the PAT slides came forward for us. But what we can see at the meetings now is that there's virtual palpation. So if you can believe this, I can be in Tucson. You could be seeing a patient in Fort Defiance. Dr. Lance, as the doc there, could put his hands in gloves. I could put my hands in gloves. Dr. Lance could palpate the patient's abdomen, and I would kind of feel what he's feeling. So very exciting technology. That is not ready for prime time, but everything else is. So certainly for new patient appointments, we've done some of this where we've done multidisciplinary tumor boards. The patient, for example, could be in Fort Defiance. The tissue slides could be there. We could look at the images together. Specialty services that you have could participate, specialty services, perhaps at PIMC, perhaps here could participate. We could review the history, the radiology, the pathology, and then talk about clinical management. So that's one way to address the needs of these patients. We've also looked at possibilities for cancer clinical trial recruitment, to then being able to say, okay, here's some options for therapy, and this would include these specific clinical trials, to see if patients are eligible before they were to actually make a trip. Again, I think facilitation of care is what's important. You hate to see a patient travel 4 hours, go through this exam, and then only be told, well, you're really not eligible. So this way, patients know ahead of time, to have some information about what is a clinical trial, perhaps have had the opportunity to review the consent form, all before they actually were physically seen. And then I think that for patients on treatment, the combination of alternating telemedicine and in-person visits can work very well.
That sounds incredibly exciting, and I think it really addresses a lot of the issues that we deal with, whether we're in a more, let's say, distant or rural environment, or even living in downtown Phoenix, not knowing about what's available, or learning about what the options are before you walk in, and then are kind of faced with, oh no, you aren't, or, well, yes, you could be in, and not really understanding what it's about. I think that's a really great opportunity.